This is the final video for Test 5 information, so it will be the final video for the semester, and I don't know who's more happy about that, you or me. So in this last video, we're going to talk about the autonomic nervous system. And so basically, the autonomic nervous system is part of the motor or efferent division, that it can be divided into the sympathetic and parasympathetic division, and there are going to be some specific reasons why you make this division. So first, what I want to do is to compare what you've seen already with muscles and the somatic nervous system to the autonomic nervous system. And so with the somatic nervous system or skeletal muscle, what you see is cell bodies that are located in the spinal cord and one motor neuron heading out to the effector organ, which is going to be skeletal muscle. Now, in the autonomic nervous system, you've got a cell body that's embedded in the central nervous system in the spinal cord, but along the way, you're going to have actually two neurons that lead out to your effector organs, and these are going to be different. These are going to be smooth or cardiac muscles, glands, or GI neurons. And so what I want you to notice here is that you've got a two neuron chain, and what that means is that at the point of synapse, you're going to have a ganglion, a collection of cell bodies in the peripheral nervous system. And that means that the first neuron that comes out of the central nervous system is going to be the preganglionic fiber, and the second neuron is going to be the postganglionic fiber. In other words, before or after the ganglion. So let's do a little bit more detailed of a comparison here. So at this top row, we're going to be looking at the somatic nervous system. In sort of this bottom row, we'll be looking at the autonomic nervous system and subdividing it into the sympathetic and the parasympathetic nervous systems. Now, all three of these have one thing in common, and it's that they have cell bodies in the central nervous system, but things start to differ from here. So looking at the peripheral nervous system, it has a single neuron from the central nervous system to effector organs. So this is going to be one heavily myelinated axon that releases acetylcholine at the site of its effector. Now, the autonomic nervous system, whether you're sympathetic or parasympathetic, you're going to have a two neuron chain from the central nervous system to effector organs. Now, there is one exception, which we'll see in just a minute. So you'll have lightly myelinated preganglionic axons that lead to a ganglion. So the preganglionic axon will release acetylcholine, which will excite the postganglionic neuron. Now, that postganglionic neuron in the sympathetic nervous system will be unmyelinated, and the postganglionic axon will release norepinephrine, also known as noradrenaline. Now, there's another thing that happens with the sympathetic nervous system, and it's that your preganglionic axon can actually release acetylcholine to the adrenal medulla. And what this will do is stimulate the adrenal medulla to release epinephrine and norepinephrine into the circulatory system. So what's the difference here? With the top scenario, you have a very targeted epinephrine and norepinephrine release. It's just basically right on top of your effector. And with the bottom scenario of these two, you have a scenario that is systemic rather than specific. Now, taking a look at the parasympathetic nervous system, you're also going to have a two neuron chain. So you'll have a preganglionic axon, which will release acetylcholine onto the postganglionic neuron at the synapse. Your postganglionic neuron will then release acetylcholine to its effector organs. So listen, this is something that I want you to notice, okay? First of all, somatic nervous system releases acetylcholine. All preganglionic axons, whether they are sympathetic or parasympathetic, release acetylcholine. And it's only the adrenal medulla and the postganglionic axon of the sympathetic nervous system that will release norepinephrine. So acetylcholine is kind of the rule, norepinephrine is kind of the exception. As far as our effector organs go, in the somatic nervous system, acetylcholine will cause the activation of skeletal muscle. It is always stimulatory. In the autonomic nervous system, the effector organs are smooth muscle, glands, and cardiac muscle. And what's the effect of norepinephrine and acetylcholine going to be here? Positive or negative, stimulatory or inhibitory, depending on which neurotransmitter you're talking about, and depending on which receptors the affective organs actually possess. We'll go into more detail about that a little later on in this video. This is just a second look at the difference between the somatic nervous system and the autonomic nervous system. So you see at the top, one neuron release of acetylcholine, which is always excitatory. At the bottom diagram here, you have the autonomic nervous system, which will have two motor neurons, a pre and a postganglionic neuron. Release of acetylcholine always from the preganglionic neuron, either acetylcholine or norepinephrine, depending on whether you're sympathetic or parasympathetic. And so your reaction is going to depend on which receptors you have. Smooth muscle can contract or relax in response to either acetylcholine or norepinephrine. Cardiac muscle can increase or decrease its rate or force of contraction depending on the neurotransmitter. And glands can increase or decrease their secretions based on what type of receptor they have and what type of neurotransmitter that is coming in contact with them. Okay, so the autonomic nervous system does consist of motor neurons that innervate smooth and cardiac muscle and glands. And so the point of the autonomic nervous system is to make adjustments that ensure optimal support for body activities. This operates via subconscious control, so you don't have any real control over your adrenaline production, for instance. And they do have viscera as most of their effectors. So the autonomic nervous system will differ from the somatic nervous system in three ways. First of all, it's got different effectors. Secondly, the efferent pathways look different, so one neuron versus two neurons. And the third is the target organ responses. So I want you to remember, again, that the organ responses in the somatic nervous system are always excitatory. In the autonomic nervous system, sometimes excitatory, sometimes stimulatory. So the effectors of the somatic nervous system are skeletal muscles. The effectors of the autonomic nervous system are cardiac muscle, smooth muscle, and glands, including lacrimal, salivary, digestive, and sweat glands. With somatic motor neurons, you have heavily myelinated axons that carry signal from the central nervous system to the skeletal muscle. With the autonomic nervous system, you have a two-neuron chain, and in that two-neuron chain, the preganglionic axon fiber is either moderately or heavily myelinated, and the postganglionic axon is actually not myelinated at all. Now, again, our difference in neurotransmitters, the somatic nervous system involves acetylcholine release, which is always excitatory at skeletal muscles. We went through this in the muscular. With the autonomic nervous systems, the preganglionic axons always release acetylcholine that is always excitatory and always causes the postganglionic axon fibers, postganglionic axons to start an action potential, resulting in the release of norepinephrine from sympathetic fibers or acetylcholine from the parasympathetic fibers. And again, the effect on the target organ depends on which neurotransmitter gets released and the receptor type that's on that particular effector organ. So here's kind of our splash page. Again, you can kind of pause this for a little bit if you want to look at this a little bit more. Okay, so this is the architecture of the parasympathetic and the sympathetic nervous systems. So besides having different neurotransmitters, they also exit the spinal cord at different sites. So in the third central nervous system video, we talked about the lateral horns. This is where we're going to get to see them. Now, one thing that I want you to notice is that there are a lot of organs shared, a lot of effectors that are shared in common. So a lot of effectors that have both parasympathetic and sympathetic innervation. So the sympathetic nervous system will mobilize the body during extreme situations, fight or flight or stress, but it will also mobilize the body during exercise in order to promote blood flow to large skeletal muscles and to decrease it to skin and some organs. So it's not always necessarily extreme or emergency So I would say that all emergency situations activate the sympathetic nervous system, but the sympathetic nervous system does not only activate during emergencies. So you'll have the sympathetic nervous system will activate during E activities: exercise, excitement, emergency, embarrassment. And so I think I've been experiencing some embarrassment with some of these videos. And so what will happen here? An increase in heart rate, an increase in respiratory rate. The skin gets cold and sweaty, so flop sweat, and the pupils will dilate. The parasympathetic nervous system is involved in maintenance activities and the conservation of energy. And so this covers D activities: digestion, defecation, diuresis. And a good example of when the parasympathetic system is actually on is when a person is relaxing after a meal. So you have a lower blood pressure, lower heart rate, lower rate of respiration, GI activities high. You have what's warm, fuzzy feeling from warm skin and constricted pupils. And so there are people who are basically adrenaline junkies, sympathetic nervous system junkies. I'm more of a parasympathetic nervous system junkies, not because of the defecation and the diuresis, but because of how you feel after a really good meal. Okay, so let's take a look at other differences in sympathetic and parasympathetic architecture. So in the sympathetic nervous system, it comes out from the spinal cord at the thoracolumbar region. And as far as the fibers themselves go, remember that we're talking about both preganglionic and postganglionic fibers. So the preganglionic and the sympathetic are short and the postganglionic are long. And where are the ganglia located? Most of them are located very close to the spinal cord. We'll see pictures of this in just a minute. The parasympathetic nervous system has its origin of fibers from the brain, so some cranial nerves are involved, and from the sacral spinal cord. So it has craniosacral outflow, whereas the sympathetic has thoracolumbar outflow. Now in the parasympathetic, it's kind of the reverse of the sympathetic with the terms of the length of fibers. It will have long preganglionic fibers and short postganglionic fibers. And because the preganglionic fibers are long, a lot of the time the ganglia are right on top of or actually in the visceral effector organs. There are some exceptions to this, which we'll see, but in most cases, the ganglia are right on top of the effector organs. We'll see a diagram again of this, which shows this a little bit better than this text. And here it is. Here's the diagram. So our outflow, as you can see, is craniosacral from the cranial nerves at the top and also the cranial region down here at the bottom. Spinal nerves S2 and S4. So there's a long preganglionic fiber and a short postganglionic fiber. Now before I go any further with this diagram, I'll remind you again of kind of how to read these. Whenever you see these dots with lines, the dots represent the cell bodies of these motor neurons, and the lines represent the axons and the axon terminals. And in this case, the darker purple are the preganglionic fibers, and the lighter purple is the postganglionic fibers. So that's kind of how you can read this. Now let's take one of these organs and expand this, and because I'm basically recording this video because of the coronavirus, let's expand the lung. And you can see here that you have your ganglion right on top of the lung itself, and you can see how short that the postganglionic fiber is. It's just right on top of the target organ. So let's talk about the different types of outflow from the parasympathetic division. So we're going to kind of separate these into cranial outflow and sacral outflow, mainly because the cranial outflow is carried by cranial nerves. And so let's see these cranial nerves. One is the oculomotor, which sends the preganglionic fiber to the ciliary ganglion, and it affects the eye. So what's going to be controlled here is actually pupil size and the thickness of the lens when it comes to focus. The facial nerve is going to send preganglionic fibers to the pterygopalatine and submandibular ganglia, and The effector organs here are going to be salivary, nasal, and lacrimal glands. The glossopharyngeal nerve will send signals to the otic ganglion, which will control the parotid salivary gland. So preganglionic fiber to the otic ganglion, postganglionic fiber to the parotid salivary glands. The vagus nerve will send signals to ganglia that are located within the walls of target organs, and these can be the heart, the lungs, and most visceral organs. In the meantime, sacral outflow goes from S2 and S4, or S2 through S4. The ganglia are located within the walls of the target organs, and these will include the large intestine, the urinary bladder, the ureters, and the reproductive organs. Sympathetic outflow arises from spinal cord segments T1 through L2, and your cell bodies, and here we get to this finally, are located in the lateral horns of the spinal cord in these areas. This is the reason why the spinal cord along this length of the spinal cord along this length will contain lateral horns. Above and below it, there won't be any lateral horns. Now, the preganglionic fibers will pass through what are called the white rami and will synapse in the paravertebral ganglia. We'll see some diagrams of this in a little bit. By the way, the white rami can also be called the white rami communicantes, therefore I'm just going to be calling it the white rami. Postganglionic fibers pass through the gray rami. These carry signals to effectors, and if you're wondering what a ramus is, we're going to find that out in just a little bit. Like now. Okay, so looking at the sympathetic trunk here, let's take a look at some of these different areas. So you're going to see the spinal cord, the dorsal root, and the ventral root, and these are going to join together to form a spinal nerve. Okay. Here you see a sympathetic trunk ganglion, so this is where you're going to see the synapse between the preganglionic and the postganglionic fibers. This is part of the sympathetic trunk, so sometimes these axons don't synapse right at the same level. They may go up and down and synapse at a different ganglion. This is the ventral ramus, the spinal nerve. So when the spinal nerve, when the dorsal and ventral roots join to form the spinal nerve, it is almost immediately going to divide right back into a dorsal ramus, which is right here. And that dorsal ramus is actually responsible for controlling a limited portion of the musculature on the back and perceiving a limited portion of the posterior skin. So there's not much to it. In the meantime, the dorsal ramus is a lot more substantive, and it's the dorsal ramus where you see the gray ramus and the white ramus splitting off from it and the gray ramus rejoining it. So this is the gray ramus and the white ramus, and so you can actually tell which one of these carries preganglionic and postganglionic fibers. So the way that you can tell this is that I told you earlier in this video that the postganglionic fibers were unmyelinated. It means they don't have myelin, which means they are not white in color. So the white-colored white ramus is going to carry preganglionic fibers, and the gray-colored gray ramus carries unmyelinated fibers, therefore postganglionic fibers. So this is a more detailed picture of the architecture of the sympathetic nervous system. And so the first thing to tell you is that the sympathetic or trunk chain ganglia, what were called the paravertebral ganglia in the prior diagram, they're split out a lot further from the spinal cord than they actually are, and this is just for effect. So these get called the paravertebral ganglia because they're right beside the vertebrae, and so again, this is kind of extended to display the white rami. So one thing that I want you to notice here is that you've got a lot of synapsing in these sympathetic chain ganglia, but you also have synapses that are a little bit further out in what are called collateral ganglia. So you see one right here, and you see 3 more of those right here. So your preganglionic fiber can be fairly long, but it doesn't extend all the way to the target organ the way that you see in in the parasympathetic nervous system. So a preganglionic fiber will follow one of three pathways after entering the paravertebral ganglia. So we are still in the sympathetic nervous system, and there are three pathways which we're going to see and that I've animated for you. So in the first pathway, you synapse with the postganglionic neuron within the ganglia that's at the level where it exits the spinal cord. In the second pathway, you can ascend or descend the sympathetic chain before you have your synapse. And in the third pathway, you can pass straight through the paravertebral ganglia without synapsing at all. So let's take a look at these three. Here's the first pathway of sympathetic innervation, and that is synapsing at the same level. So basically, you're going to start out here at the cell body of the motor neuron. From here, you're going to proceed through the ventral root, join the spinal nerve, go through the white ramus, and you'll synapse in the sympathetic trunk ganglion. Then your postsynaptic neuron, the cell body of which is in this ganglion, will carry the signal out to your effector. So this is the simplest and first pathway of sympathetic innervation. In this pathway, we see something that's a little bit more complicated. The architecture is a little bit more complicated. So you see your signal starting with the cell body of the motor neuron in the lateral horn. So it will come out through the ventral root and it will make its way into the ganglia. Now, instead of synapsing here, it will pass up to a different ganglion. It can be either above or below, and so it will come out at one level and synapse at a higher or a lower level, and this case shows you a higher level. And from here, from the synapse, your postganglionic neuron will then carry signal to your effector. So that's your second pathway of sympathetic innervation, synapse at a higher or at a lower level. In the third pathway of sympathetic innervation, here's what you're going to see. Signal starting at the lateral horn of the gray matter of the spinal cord. It will come out the ventral root into the spinal nerve, but it goes all the way through that paravertebral ganglion and goes out to what's called a collateral ganglion, and the celiac ganglion is a good example of this. And so at this distant or collateral ganglion, you'll see the postsynaptic neuron carry its signal to the target organ. So I want to make this clear. The way that this does differ from the parasympathetic nervous system is that you're still not seeing this post-sympathetic neuron start right on top of the target organ. There's still some distance there. So again, your outflow is thoracolumbar between T1 and L2. The other thing that this picture shows, I think, pretty nicely is that the ganglia actually extend above and below where the actual outflow is. So you'll only have outflow in the thoracolumbar region, yet you've got three separate cervical ganglia, and the reason why is because of that second type of pathway where you can have a synapse occur at a level above where you came out from the spinal cord. So these paravertebral ganglia form part of what's called the sympathetic trunk or chain, and there are 23 ganglia. 3 cervical, 11 thoracic, 4 lumbar, 4 sacral, and 1 coccygeal. So you can see the sacral extending down further from the thoracolumbar output, and the cervical extending upwards from the thoracolumbar output. So again, the fact that you can synapse at a ganglion above or below where the outflow is, this is the reason why you're going to have additional ganglia that extend above and below where the nerves themselves actually come out from the spinal cord. So again, here's another big picture, and now hopefully some of this is going to make some sense to you. And so right here, you can actually see some of these synapses. Let me circle them here. So this would be a synapse that is below the level. Okay, these would be synapses that would be above the level where you have the outflow. You've got collateral ganglia out here. You've got a lot of synapses right here on the same level. You've also got plexuses um, out here, and these are just areas of greater complexity where you have your cardiac and pulmonary organs. Here's another distant ganglion. Okay, and what I meant by short pre and long post, a great example of this is actually the sacral splanchnic nerves, which come out from the sacrum and travel to the genitalia. Okay, so let's talk about the types of neurotransmitters that we have and the types of receptors that you find on the different tissues. So if acetylcholine is your neurotransmitter, your receptor type gets called cholinergic. So choline after the choline portion of acetylcholine. There are two types of cholinergic receptors. The first is nicotinic. Its major location is in all ganglionic neurons and also in adrenal medullary cells. The effects of binding of acetylcholine here is excitation. The other type is muscarinic, which is in all parasympathetic target organs. And your effective binding is excitation in most cases, but is actually inhibition of cardiac muscle. So acetylcholine will actually act to slow the rate of the heart rate. There are limited sympathetic targets that have muscarinic receptors, eccrine sweat glands, and in this case acetylcholine will actually activate them. Blood vessels and skeletal muscles, which are actually vasodilated, which is pretty much the same thing as activated. Okay, the other neurotransmitter is norepinephrine and epinephrine. This gets released by the norepinephrine and epinephrine that gets released by the adrenal medulla. You have adrenergic receptors. So remember, adrenaline is another name for epinephrine and norepinephrine, therefore adrenaline adrenergic. What are your major locations? It depends on which receptor type you have. So beta 1 is one type of receptor, and it's in the heart predominantly, but also in kidneys and in adipose tissue. So this is the reason why somebody can actually take what's called a beta blocker. So adrenaline will increase heart rate and strength and stimulate renin release by the kidneys, but if you've got a pretty severe blockage in your coronary arteries, then what you don't want to have happen is for your heart rate to increase and the strength of your contraction to increase. So a beta blocker, what it basically does is to block the receptor by binding to the receptor at the place where adrenaline would normally be. So when adrenaline shows up to these blocked beta receptors, then it just bounces straight off. It can't bind because there's already something there. It's basically like trying to put a key in a lock if there's a broken off key that's already in there. It's just not going to work. So let's see. Well, you'll find out about a consequence of this when you come back and take AMP2 with me, and we cover the endocrine system. Okay. Beta 2 receptors are present in lungs and most other sympathetic target organs. So they're also in blood vessels that serve the heart, in the liver and skeletal muscle. Your effects are mostly inhibitory, notably on blood vessels serving the heart. It's excitatory. So in the lungs, for instance, it will dilate blood vessels and bronchioles. And so I want you to bear this in mind, that the smooth muscle that's in like the GI tract and the smooth muscle that's in the, okay, let me give another example. The smooth muscle that's in the coronary blood vessels and the smooth muscle that's in the bronchi, how are they going to respond to adrenaline? The smooth muscle that's in the coronary arteries, it's going to constrict, narrow those arteries. And in the lungs, think about what happens if you give somebody an EpiPen. It's going to open their lungs back up. So the same tissue, smooth muscle, responds differently to the same neurotransmitter because they've got a different receptor. Okay, beta 3 receptors you're going to find in adipose tissue, and this will stimulate lipolysis in response to adrenaline release. Alpha 1 receptors are in blood vessels that serve the skin, the mucosae, abdominal viscera, and so forth, and in virtually all sympathetic targets except for the heart. And so the effective binding is excitation, so it'll constrict blood vessels and visceral organ sphincters, and by the constriction of the smooth muscle in the pupils, it will dilate the pupils of the eyes. Alpha 2 receptors are in um, the pancreas and in blood platelets, and it will inhibit norepinephrine release from adrenergic terminals. It'll inhibit insulin secretion by the pancreas, and it'll promote blood clotting. So now the next thing that I want to say on the next slide is one of the most important things that I can tell you in either AMP1 or in AMP2. And it's this: the ability of any cell, tissue, or organ to respond to any chemical signal is completely dependent on its receptors. And so I know about this from personal experience. So right before I had my angioplasty, I was taking a beta blocker to try to ensure that I wouldn't have a heart attack before the procedure. So I still remember the Saturday before my heart surgery. I was watching a college football game. I was really into it. Was all excited, and I thought, oh crap, my heart should really be going like a trip hammer here. But I was on the beta blocker, so I was showing every other sign of an adrenal reaction. You know, heavier breathing, probably sweating a little bit, probably a little bit flushed, and I checked my pulse rate. My heart is just going nice and slow, like nothing was happening at all. So with that beta blocker occupying the receptors of that heart tissue, it actually meant that the heart tissue no longer had the ability to respond to adrenaline. So if you cut off or if you stop an organ's ability to respond to a signal, you can do that by blocking receptors. And fortunately for cardiac patients, that specific type of channel, the beta 1 receptor, is found mainly in heart tissue. So that beta blocker doesn't have tremendous effects on the rest of your system. Okay, acetylcholine will affect cholinergic fibers, norepinephrine will affect adrenergic fibers, and again, as I just said, the neurotransmitter effects can be excitatory or inhibitory depending on your receptor type. Acetylcholine gets released by all preganglionic axons for everything in the autonomic nervous system, both sympathetic and parasympathetic, and also acetylcholine gets released by postganglionic axons of the parasympathetic nervous system, and in a few sympathetic postganglionic neurons, the ones that innervate sweat glands. So here you see these three scenarios. You see at the top, the sympathetic division, your innervation to most effector tissues, acetylcholine with the preganglionic, norepinephrine at the postganglionic. With sweat glands, acetylcholine at the pre and postganglionic. And with the parasympathetic division, you get acetylcholine at the pre and postganglionic. And let's just point this out with some arrows. You can see here in all preganglionic fibers, acetylcholine release, and in postganglionic fibers, acetylcholine in parasympathetic and in sweat glands, and norepinephrine in all other sympathetic synapses. So the two types of cholinergic receptors are nicotinic and muscarinic. You find nicotinic receptors at motor end plates in skeletal muscles, the hormone-producing cells of the adrenal medulla, again, all cell bodies and dendrites of postganglionic neurons in both the sympathetic and the parasympathetic divisions. And if you bind acetylcholine to nicotinic receptors, it is always stimulatory. Now, with muscarinic receptors, you're going to find these on all effector cells that get innervated by postganglionic neurons in the parasympathetic division. So, all parasympathetic targets have these, and the effect of acetylcholine binding to these muscarinic receptors can either be excitatory or inhibitory. So there are different forms of muscarinic receptors that can either be excitatory or inhibitory in response to acetylcholine. So here's an example of a cholinergic pathway. Again, you have the preganglionic fiber releasing acetylcholine. The postganglionic fiber has nicotinic receptors on it. When you look at the effector cell, it's also having acetylcholine released to it. But on the effector cell, you're going to have muscarinic receptors. So again, just remember, postganglionic fibers always respond to acetylcholine by sending out their own action potentials. Target organs that are targeted by acetylcholine that have muscarinic receptors, sometimes they're inhibitory, sometimes they're stimulatory. So again, the two types of adrenergic receptors are alpha and beta. You've got alpha 1 and 2 receptors. You've got beta 1, 2, and 3 receptors. So basically with the sympathetic nervous system, you have either the release of norepinephrine at all effectors except for the sweat glands. And in sweat glands, your receptors are going to be muscarinic. With your other effectors for the sympathetic nervous system, they're going to be adrenergic. So, of course, they're going to be adrenergic because acetylcholine doesn't get released at postganglionic neurons of the sympathetic nervous system. Now, most visceral organs do get innervated by both sympathetic and parasympathetic nerves. This sets up a scenario called dynamic antagonism. So basically, this is the idea behind dynamic antagonism. So both systems, parasympathetic and sympathetic, are always on. It's just that one will predominate depending on your needs. So if you need an increased heart rate, increased respiratory rate, then sympathetic will predominate. If you need to increase your GI and renal activity, the parasympathetic will dominate. But they're both always on, and as I said, the levels of control, which one is in charge, depends on what your body's needs are, not only from day to day, but from minute to minute. So the sympathetic division will control blood pressure by causing something that is called intrinsic vasomotor tone, and that's sort of a minimal constriction or the minimum level of constriction in blood vessels. And basically, if you have a higher intrinsic vasomotor tone, this results in blood vessels kind of closing down, and that's kind of like putting your thumb over the end of a garden hose. It'll increase the velocity and the pressure of blood in the bloodstream. Now, blood vessels only have sympathetic input. They don't have parasympathetic input going to arterioles. And what this means is that your sympathetic nervous system can crank up your blood pressure, but your parasympathetic cannot bring it down because it doesn't have fibers that lead to arterioles. There are other areas that are regulated by the sympathetic nervous system but don't get innervation from the parasympathetic division. So these include the adrenal medulla, sweat glands, which are involved in thermoregulation, and the erector pili muscles. So we talked about this earlier this semester in the integumentary system. The erector pili muscles are what give you goosebumps. And so when you're scared, you get goosebumps right away. Bang, sympathetic stimulation, goosebumps. But even when you get calmed back down from whatever fright or whatever temperature gave you the goosebumps, they go back down a whole lot more slowly because your sympathetic nervous system can't relax those muscles. It doesn't innervate them. Okay, so the kidneys, the release of renin is sympathetic to, is controlled by the sympathetic division, not by the parasympathetic. Vasoconstriction I just talked about. And metabolic effects can be controlled by the sympathetic division, but not by the parasympathetic. So you can get increased metabolic rate of cells from the sympathetic nervous system, but you don't get a corresponding decrease from parasympathetic. You can raise your blood sugar level with the sympathetic nervous system. You can't decrease it with the parasympathetic. You can mobilize fat with the sympathetic nervous system. You can't unmobilize it with the parasympathetic. And the other thing that the sympathetic nervous system does is to stimulate the reticular activating system of the brain. And as you now know, that's involved in arousal and consciousness. So a good scare will wake you up really quickly, and so you'll become awake immediately. But falling back asleep, that takes a while, and it's because you don't have a parasympathetic input that will calm down the reticular activating system. Now, there are a few cases in which you get cooperative effects in the autonomic nervous system, and as it turns out, the male reproductive system requires cooperation between the sympathetic and the parasympathetic divisions for normal functioning. And so, in men, the parasympathetic system is responsible for vasodilation of blood vessels that will cause a man to have an erection. But it's the sympathetic nervous system that's responsible for ejaculation and the peristalsis that moves semen through the urethra. And so ejaculation is actually a spinal reflex. We'll talk about autonomic spinal reflexes in just a little bit. So it is to a great extent involuntary. That's the reason why, just to talk frankly, that men can have control issues. It's because it can be as much of a reflex as a knee-jerk reflex. Okay, so the parasympathetic nervous system has short-lived and very highly localized control. If you'll recall, the ganglia and the post-sympathetic fibers are right on top of the target organs, and this means that it's a very specific target. So it's short-lived, there's a highly localized control, and one of the reasons why is something that we saw when we talked about the muscular system, and that's an enzyme called acetylcholinesterase that will take acetylcholine back up and degrade it. So acetylcholine gets inactivated really quickly, and that means that the parasympathetic nervous system has a very short-lived control. Now, the sympathetic nervous system has a more long-lasting and diffuse or spread-out effect. Now, the main reason why it has a diffuse effect is because it's got an organ that dumps a boatload of it into the bloodstream. So, of course, there's going to be a much more diffuse effect around the body. It's more long-lasting because norepinephrine gets inactivated more slowly than acetylcholine. There isn't a comparable enzyme to acetylcholinesterase that degrades norepinephrine. In fact, the epinephrine that's released by the adrenal gland is active until it gets destroyed by the liver. And another thing that plays into this response lasting longer is because it uses a second messenger system, but I'm not going to worry about you knowing that this semester. That's more of an endocrine system kind of topic. Now, the hypothalamus is your main integration center for autonomic activity. So the hypothalamus is going to receive inputs from the cerebral cortex. So this could be emotional inputs or recognition inputs. And it's also going to receive input from the limbic lobe. And so the cerebral cortex can recognize something as frightening. The limbic lobe will go, hey, be frightened. So you'll receive input signals from both the limbic lobe and the cerebral cortex. Now, what the hypothalamus can direct is the reticular formation of the brainstem, which will regulate pupil size. It'll also regulate respiration, heart rate, blood pressure, swallowing, and so forth. And it will also regulate events down the spinal cord, which include urination, defecation, erection, and ejaculation reflexes. Okay, so you see the reticular formation being bossed by the hypothalamus and the spinal cord. Now we're going to take a look at these autonomic reflex arcs. And so this kind of represents a traditional reflex arcs where you've got a sensory neuron that brings a signal in, and then you have a motor neuron that brings a signal out. And so in this case, a sensory receptor in the viscera will send signals up the visceral sensory neuron, and your pathway goes like this. So up the sensory neuron, past the dorsal root ganglia to your synapse, in this case in the lateral horn of the gray matter, the spinal cord. Now your outflow, there may be a dorsal horn interneuron in between these two neurons. It's just that they showed a simpler picture. Also, your integration center doesn't have to be the spinal cord. It can be within the walls of the gastrointestinal tract. Now, your outgoing pathway, your efferent pathway, involves two neurons, as does the autonomic nervous system. So you'll start out with a cell body in the lateral horn of the spinal cord, and you'll travel out along your preganglionic neuron. You'll synapse, in this case in the ganglion. I want you to remember that you could also go up or down that ganglion, and your postganglionic neuron will then carry a signal out to your effector. So that's basically how an autonomic reflex arc works. And so in this case, you don't have to wait for the brain to signal this. So this is involuntary control, and it's a faster reflex. And as I mentioned before, ejaculation is a spinal reflex, and so this is why sometimes it can be difficult to control. But one other thing that you may find to be interesting and kind of creepy at the same time is that someone who is quadrilegic or paraplegic, as long as there is a neural connection between their genitalia and their spinal cord, someone may not feel sensation, but they can be stimulated to ejaculate. And so this is how someone who is paraplegic or quadriplegic could still manage to have children. Now, this last slide doesn't have anything to do with the autonomic nervous system, but it was a place where I thought was a good, I thought this was a good place for talking about this. So, one of the things that I hope that you've learned is that outgoing nervous signals can travel along similar pathways, at least in the very beginning. So, you're going to exit from the spinal cord at the spinal nerves, even though you split pretty quickly into the motor neurons that go on down the spinal nerve, or the autonomic neurons that enter the paravertebral ganglia. Still, you've got some common pathways for at least a short time. Now, when pain afferents or sensation, when those come back in, they're going to travel along the same pathway as somatic or muscle/skin pain. So sometimes visceral pain can feel like somatic pain. And the classic example of this, if you look at the heart, you can have signals coming in from the heart that are strong enough to where your brain, because it's receiving signals along a particular pathway, will also think that it's getting pain signals in radiating out in the chest, down the left arm, and up the left side of the neck. So you can see some pretty unusual things happening. The liver can give you referred pain up at the shoulder, the gallbladder, about where your trapezius muscle is. The gallbladder, of all things, can give you pain in your shoulder. The appendix is pretty localized. The colon is pretty localized. Although I will tell you from personal experience that sometimes you can have an injury in one portion of the colon and have it show up as pain, referred pain in a different area. That happened to me when I had diverticulitis. So the kidneys have got a very broad range of pain. If you'll notice the ovaries, that's pretty localized. I'll just go ahead and tell you right now that the areas where you have kidney pain, the referred pain for testes goes from everywhere where the kidneys are and all the way up to the rib cage. So any guy who's taken a shot in the wrong place can tell you that the pain spreads all the way up to the rib cage and slightly down the thighs. That's the reason why it's so disabling. But referred pain is what happens when you have pain happening where you're perceiving pain in an area that doesn't have damage, and the reason why is because those areas are following the same pathways as the areas that are receiving damage. So the heart's receiving damage, the chest, the left arm, and the neck aren't, but it all feels like it's taking damage because, again, the heart is receiving these really strong signals from a particular area. That's it. I hope that these videos have proved useful, and I hope that the class has proved useful, and I really do hope to see many of you in A&P class in the coming year.